This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Out of This World. Want to know what substance has been used at parties since 1799 and is still popular on sites like TikTok today? Why it's used as much as 600 times a day and where you can find it in the grocery store? Then listen to find out. Today's episode starts with a text message. It's one of your residents asking you to see a friend of hers. He's a 22-year-old man with difficulty walking, and he's currently in the emergency department. She texts that she'll meet you there shortly because he only agreed to go to the ER if she promised to walk his dog first. His chart reports the following vital signs: temperature of 98 Fahrenheit or 36.6 Celsius, heart rate of 90 beats per minute, respiratory rate 18 breaths per minute, oxygen saturation 100% on room air, and blood pressure 120/80. In other words, completely unremarkable. Entering the room, he's sitting on the stretcher fully dressed. This is a serious pet peeve of mine because you can't do a thorough physical exam unless the patient is undressed in a gown. His gown is at the bottom of the bed under his shoes, which are also still on. You decide to talk to him first to take the history and then ask him again to get undressed after you step out. He says he's been having difficulty walking for weeks. His legs are weak and his balance is off, causing several falls over the past few days. He denies any significant traumatic injuries from the falls themselves. Also, his hands and feet are numb. He denies fevers and chills along with current or recent upper respiratory infections, and the rest of his history is unremarkable. He denies all other symptoms, including past medical history and medicines. He doesn't smoke, reports occasional alcohol, and denies illicit drug use. He doesn't work. He's still a student. You ask him to get undressed so you can examine him. Back at your computer, you order some basic lab work and a head CT. When you return to the room, he's still completely dressed. He looks at you embarrassed, saying he can't unbutton his shirt. He says his girlfriend helped him dress this morning. So we have an otherwise healthy 20-year-old man who can't get undressed? What's happening here? You ask him to try to see what the exact problem is. He fumbles with a button, but his fingers don't grasp it, and he can't seem to move his fingers in a particular direction. He's still sitting on the stretcher while doing this, and his torso is moving back and forth involuntarily. This is called truncal ataxia, and neurologically it goes along with and contributes to gait instability. So you help him get undressed and into the gown. And on exam, he has diminished sensation in his hands and his feet. He can move his legs, but they're weak. Basically, he has the strength of a 90-year-old, not a 20-year-old. The findings you notice are worse in the legs than in the hands. You have him stand up and grasp his arm so he doesn't fall, then ask him to take a few steps to check his gait. He lurches forward and almost falls with the first step. You grab him and help him back to bed instead. Well, this isn't looking good. What could be causing this? Common things like strokes or intracranial hemorrhage, bleeding in the brain, cause unilateral symptoms just on one side. Most people would order a head CT just in case, though it's pretty likely low yield here. An MRI might be more helpful, but it'll take a lot longer to get. The numbness in his hands and feet is in what we call a stocking glove distribution, a classic description of peripheral neuropathy caused by local nerve damage. It's very common. You may be suffering from it yourself or know someone who has it. It's caused by things like diabetes, chemotherapy, and alcohol misuse. Peripheral neuropathy, by definition, means affecting peripheral nerves. In contrast, ataxia is caused by a problem with the central nervous system, meaning the brain or the spinal cord. So peripheral neuropathy, while present here in our patient, isn't causing his balance problems. Also, it doesn't cause significant leg weakness like this, so we need to look further. You've probably heard of Guillain-Barré syndrome, a disease occurring after infections or very rarely vaccines. It's an ascending weakness and paralysis beginning in the feet and rising to the head. Our patient has had symptoms for weeks. If it was Guillain-Barré, the truth is he'd already be dead. ER doctors always worry about cauda equina syndrome, resulting from compression of nerves in the back. The spinal cord ends in the cauda equina, becoming a series of nerves running from the back all the way down to the toes, and compression here causes weakness in the legs, sensory loss in the groin, and bowel and bladder incontinence, i.e. peeing or pooping on yourself. The compression happens from things like cancer and infection. He denies incontinence, and again, we wouldn't see a central problem with ataxia with this. Bottom line, this sounds like a problem for neurology. The patient's results come back. As expected, his head CT is normal. There is an interesting finding on his labs. He has anemia, meaning a low blood count. Nothing dangerously low to suggest bleeding, but low for an otherwise healthy 20-year-old man. Anemia is very, very common, especially in women, and we most often see iron deficiency anemia causing small red blood cells. Our patient, though, has red blood cells which are macrocytic or large. This isn't as common, and it's often associated with alcohol use and vitamin deficiencies. In fact, as you think about it, the patient's symptoms look a lot like pernicious anemia, a disease caused by a specific vitamin deficiency. So this is question number 1. It's a tough one. What vitamin deficiency causes macrocytic, large red blood cells, and pernicious anemia? A, vitamin A, B, vitamin B12, C, vitamin C, or D, vitamin D? The answer is B. Vitamin B12 deficiency causes macrocytic anemia. Pernicious anemia is a hereditary problem resulting in the inability to absorb B12. Vitamin A deficiency is extremely rare and it causes night vision difficulties and ultimately blindness. Vitamin C deficiency, I'm sure you know, is scurvy, and vitamin D deficiency leads to osteoporosis. So can we test for B12 deficiency? We can send a B12 level, and I would send one in our patient, but it will take days to come back, and it might not be helpful. More on this in a minute. His symptoms are classic, so I'd continue down this path. How do you get B12 deficiency? Well, pernicious anemia, as I just said, is a hereditary condition, but B12 deficiency these days is more often acquired. Vegan diets might result in deficiency from not eating enough B12. Gastrointestinal problems like Crohn's disease or surgical removal of the bowel can cause malabsorption. Heavy alcohol use results in B12 deficiency, and age is also a factor for decreased absorption. The patient confirms he's not a vegan, has never had surgery, and again denies more than a drink or 2 per week. So question number 2, what drug of abuse is notorious for causing symptoms of B12 deficiency? A, MDMA or ecstasy, B, cocaine, C, fentanyl, D, nitrous oxide or whippets? The answer is D, nitrous oxide, sometimes called whippets, or more recently known as galaxy gas. So never mind about calling neurology, at least not for help with the diagnosis. You ask him if he's using nitrous oxide. His eyes widen in surprise. After several moments of silence, he nods yes. Reluctantly, he says he's been inhaling galaxy gas several times per day, saying he's very stressed from the demands of school. Inhaling the gas makes him feel more relaxed. Wait a minute, did I hear you say? During the history, the patient denied illicit drugs. And now you're telling me this is due to drug use? Yes, patients very often aren't forthcoming about substance use, but in this case, it's our mistake. Nitrous oxide is legal and therefore not illicit, so he actually told us the truth. In medical school, we're all taught to use extremely specific language. For example, if you ask a patient what brings you to the ED today, a mistake I've made myself, you'll often hear my car or the ambulance rather than their chief complaint. What is nitrous oxide? Where do you get it? And what does it do? Well, first let me clarify a few points to clear up any confusion. A lot of different substances are abused as inhalants. We've talked previously about the largest category, hydrocarbons, found in spray paint and keyboard cleaners, for example. Listen to the Deadly Breath Equals Sudden Death episode for more about this type of exposure. Nitrous oxide is also used by inhalation, but it's a completely different compound with different toxicity. This drug is unfortunately everywhere and easy to come by. It's legal and in your local bodega or grocery store. And that's question number 3. Where do you find it? A, in whipped cream chargers, B, olive oil spray, C, hairspray, or D, spray kitchen cleaners? The answer is A, whipped cream chargers. Nitrous oxide is the propellant from the whipped cream machine chargers that you might use in your house or see at a restaurant, thus the name whippets. It's found in small cartridges or larger canisters. Often the gas is put into a balloon for slower inhalation like with whippets. It can be inhaled directly from the canister, and Galaxy Gas is actually the brand name of some larger canisters, many apparently with flavored gas, which for some reason became popular on social media, leading to the newer slang term calling nitrous oxide Galaxy Gas. Users report a calm, relaxed state with feelings of euphoria. They can feel dreamy and detached, and in fact, it's been called, quote, an atmosphere of heaven, end quote. Unwanted side effects include dizziness, nausea, and vomiting. Hallucinations are possible. What's the toxicity of nitrous oxide? Well, we have to separate acute from chronic exposure. Acutely, there is a risk of overdose and death, but it's rare. The gas itself has a short half-life, and symptoms last for only a few minutes. If a person stays connected to the nitrous oxide for more than a few minutes, then oxygen is displaced from the lungs, leading to hypoxia and death. This risk is higher when patients intentionally asphyxiate themselves by placing it into a bag over their head. There are definitely some tragic cases, including cases associated with driving while intoxicated. For example, a woman killed a teenager in her car after taking nitrous oxide while driving, losing consciousness, and crashing the vehicle. Nitrous oxide is easiest to obtain in these smaller canisters, but it does come in large canisters like oxygen tanks. Why? Because we use it in medicine, especially dentists. The effects range from mild euphoria and reduced anxiety to complete anesthesia. And this difference in medicine has to do with the concentration. Usually, nitrous oxide is mixed with oxygen in a low concentration to prevent hypoxia and death, and then also the length of exposure as well determines the symptoms, as I mentioned earlier. At a dental visit, generally the patient stays awake but is calmer and less anxious. You might see this at a party where people are using whippets. Someone uses the tank to fill up balloons with nitrous oxide, which other party-goers inhale. And this brings us to another potential issue, frostbite and burns. The tanks and cartridges become extremely cold as the gas is released, and patients can get severe burns and frostbite from holding the cylinders. Oral burns are reported after inhaling directly from cartridges. The burns, though, are often seen in a surprising location, inside the thighs. Why? Because the person filling balloons holds the nitrous tank between their thighs. The burns look mild initially, but then develop into more severe ulceration and even gangrene in the days following. So, if you go to the dentist, should you say no thanks to nitrous and avoid weakness and paralysis? No, actually, our patient didn't develop these severe complications from one use at the dentist or even inhaling whippets at a party. These effects are due to problems with B12 caused by chronic exposure and very frequent exposure to the gas over weeks and more commonly months. It's really chronic exposure with frequent use that causes the real problems. Interestingly enough, we don't know exactly how nitrous oxide works, not the mechanism of its anesthetic effects or the mechanism of its chronic toxicity. But it's believed that nitrous oxide interferes with an enzyme called methionine synthase, resulting in B12 inactivation in the body and therefore symptoms of B12 deficiency. Like B12 deficiency itself, chronic nitrous abuse causes subacute combined degeneration in the spinal cord. Our patient has the classic symptoms of this, including a combined sensory motor problems with numbness and tingling, weakness, and ataxia. While I said earlier I would send the B12 levels, some patients do have low levels, but others have normal B12 levels, so it's not always that helpful, to be honest. The history of nitric oxide use is extremely fascinating, including its other name, laughing gas. It was discovered in the 1700s and became extremely popular not for medical use, but for recreational use. In 1799, chemist Humphrey Davy, researching treatments for tuberculosis, popularized nitrous oxide after taking it himself and reportedly laughing, screaming, and leaping around the laboratory. He then conducted parties at his house with laughing gas inhaled from a green silk bag, asking users to record their experience. Samuel Taylor Coleridge, the poet, said it was, quote, like returning from a walk in the snow into a warm room, end quote. Davy himself developed an addiction, using it 3 to 4 times per day, and eventually constructing an airtight breathing box in which he nearly died several times. Eventually, he stopped, was knighted, and had a lauded career as a chemist. Wealthy British people continued holding laughing gas parties well into the 1800s. In the United States, nitrous oxide was used in theater performances where patrons were called to the stage, given laughing gas, and then entertained the audience with their ridiculous behavior. In modern times, nitrous oxide was popular in the 1960s and 70s along with psychedelics, and at raves and dance parties in the 1990s and 2000s. More recently, as I mentioned, nitrous oxide brand name Galaxy Gas has been popularized on social media. Abuse is particularly common amongst teenagers and people in their early 20s, at least in part because it's legal and easy to obtain. It doesn't show up on drug tests, and in fact, it's difficult to test for, period, including post-mortem because it has a very short half-life. Your resident bursts into the patient's room with a box under her arm. It clanks loudly as she thrusts it towards you, obviously arriving at the same conclusion you have. The box is filled with 20 or 30 canisters of nitrous oxide intended as chargers for whipped cream machines. Your resident entered his apartment to walk the patient's dog, and she discovered the entire floor was covered in empty canisters. Think this is a fictional exaggeration? It isn't. I've had patients with similar apartments, and there are reports in the medical literature of patients using as many as 600 canisters per day, if you can believe it. I don't even know how there's that much time in a single day. In addition to the neurological problems our patient has, chronic use can also cause psychiatric changes, including mood disturbances and psychotic episodes. So question number 4, how do we treat nitrous oxide toxicity in our patient? A, antibiotics, B, oxygen, C, B12 supplementation, D, N-acetylcysteine or NAC. The answer is C, B12 supplementation. It does help treat toxicity. The most important thing, of course, is stopping the nitrous exposure and use. Antibiotics won't help, and N-acetylcysteine is the antidote for acetaminophen toxicity. If you said oxygen and we're thinking of acute toxicity, then I'll give you credit. Certainly, if a patient was hypoxic after an acute exposure, oxygen would be the treatment, but it won't help our patient with normal breathing and oxygen levels. So if he stops using nitrous oxide and takes B12, will our patient get better? He should, and many patients do, though it's definitely not a guarantee, and some people have been permanently paralyzed after severe chronic nitrous oxide use. The dose and route of B12 supplementation is not well studied, but it should be given in high doses either orally or as intramuscular injections. And also methionine supplementation is recommended. If you remember, methionine synthase is the enzyme implicated in toxicity, so extra methionine might also help, and there's very little downside to giving it. Given the severity of our patient's symptoms, you'd probably admit him to the hospital, though the symptoms will take time to improve regardless of admission or discharge. Alternatively, he could be referred to a neurologist as an outpatient for ongoing care. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. Because of nitrous oxide's recent popularity in the US and Europe, I should say actually, one study in the UK reported that nitrous oxide was the most popular drug after cannabis amongst 16 to 24-year-olds. Regulations have been passed to try to reduce this risk. For example, in New York City, you need to be 21 to purchase nitrous canisters and cylinders. Some countries in Europe have limited the number of canisters that can be purchased at one time because, for example, they're sometimes sold in boxes of 300. Nobody needs that much whipped cream, not even a restaurant. Remember that nitrous oxide is N2O, and it's different than nitric oxide, NO, a signaling molecule found inside our cells and the target of some drugs like Viagra. The last question is today's pop culture consult. Which artist has been associated with nitrous oxide use? A, Drake, B, Lady Gaga, C, The Chemical Brothers, or D, Kanye West? Follow the Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available on the website at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.